welcome everyone. I think Mark set the stage quite nicely, and the key theme, of course, as always, is that healthcare is very complicated. Now we're going to get a chance to hear from the stakeholders. I want to introduce our panelists. We have Betsy Imholt. She's Director of Special Projects from Consumers Union. Tom Prisilak, who is the President and CEO of Cedars-Sinai Health System in Los Angeles. Colin Drozdowski, who's a Vice President for National Provider Solutions at Anthem. And Jeffrey Bajenhoff, sorry.
All right. I'm used to it.
Yeah. You're very understanding on that. You coached me before, too. He's the president-elect of the American Society of Anesthesiologists. And so I think we're going to let each of them provide a 5-minute to 7-minute background on this topic, because we do want to make sure all the positions are represented. But I think, you know, to set the stage, the Partnership for Fighting Chronic Disease published a survey recently, and 7 out of 10 people are reporting one or more coverage issues, with insurance not covering as much as they expected, and with an unexpected medical bill being the primary problem in 58% of the cases. And so this is widely prevalent in a way people may not understand. On the other hand, as I think Leonard Schaeffer pointed out, the best tools we have right now for controlling healthcare costs are copays, deductibles, and also the ability to select narrow networks and providers that provide efficient care. And so the challenges for us as we think about where healthcare is going are enormous, and we need to keep those in mind. So let me turn it over to Betsy first.
You want us to stay seated?
Yes.
Okay. Good morning. He's just shrunk our time from 7 to 5 minutes. So I'm going to race through what I can here.
You can have your full 7.
I'll take the full 7. Okay. Well, I think it's fitting and appreciate that the consumer perspective is jumping this off, because, of course, it's consumers who are the ones that get stuck with these surprise, unexpected bills. Consumers Union has a national campaign to stop surprise out-of-network bills. And our work started with some egregious cases that came to our attention in New York, including one of a woman named Claudia Naffo. And I have to just put the human face on this for a minute to start out. She's a concert pianist in New York. And when she needed cervical spine surgery in 2012, she did her due diligence. She's a savvy consumer, like a Consumer Reports reader. She went to make sure that the surgeon was in network, the recommended surgeon, by checking with the hospital website and several different sources, and they all confirmed that this was an in-network surgeon. Yet a month after the surgery, she found that she got a $100,000 bill, and it is one of those alarmingly huge bills for the total amount of services. The insurer sent her a check for $67,000, which is a pretty good chunk. She endorsed it over to the doctor, but only then learned that the doctor for several years had not been in the network. So she was going to be liable for $33,000. It's a saga that led to some heavy-handed collection tactics, to her even considering divorce as a strategy to protect her family assets, and incredible stress for a woman recovering from a major surgery. So luckily, her story has a happy ending, because with her perseverance and with the intervention of the New York State Department of Financial Services, the bill was waived. So her story ended well, but not so for the many thousands of people who've contacted Consumers Union over the past couple years from across the country with these stories. Our National Research Center did a nationally representative survey in 2015, and found that 1 in 4 people over the prior 2 years had had a bill from a doctor that they didn't know and didn't expect to get a bill from. Of those who had been hospitalized in the prior 2 years, 1 in 4 had a bill that was charged out-of-network rates when they expected it to be in-network. And we know from secret shopper work we've done in California that, as other speakers have mentioned, for some specialties, such as anesthesiology, in-network hospitals may have no providers at all in-network. As to whether the problem is growing, just to keep the discussion lively, I have to offer a counter view, because I'm not necessarily convinced that the problem is growing. Several reasons why the issue has gained prominence are, first of all, many more people are covered with individual market coverage for the first time. So the sheer number of people covered is more, and therefore any problems in the market are going to be compounded. Secondly, some products are rising in prevalence. Someone mentioned EPOs, and that kind of product that doesn't cover out-of-network cost at all. Those are growing, we see at least in California, in prevalence. And third, there is this issue of some specialist consolidation going on, so that we have found, for example, anesthesiologists coming together in groups and then being unable to negotiate a contract with the carrier, and therefore not joining us in network. Many of the stories we've gotten are older stories from prior to the Affordable Care Act. And I know in California, for many years, we've been working on this issue. Since 2009, there was a case, well, probably before that, there was a case involving emergency coverage. So I'm not totally convinced it's a growing problem. It's certainly not a new one. But I do agree with the paper that the market incentives are not there for the providers and carriers to correct it themselves, and so we do need policy solutions. I was asked to talk about what we think are good policies from the consumer perspective. And obviously, it's to get the consumer out of the middle of these contract and reimbursement disputes between carriers and providers. But the consumer interest also is, in the longer term, to contain premiums and health system costs. So here are three elements I would give of a good policy solution. And I'm speaking on the state level because that's primarily where we've worked and we've had a lot of success. First, require that consumers pay no more than out-of-network, no more than in-network costs for those out-of-network services where they didn't choose to go out-of-network, but it was sort of foisted upon them. And count that cost sharing that they do pay toward their deductibles and out-of-pocket maximums. Second, explicitly ban balance billing. And it's probably also a good idea to prohibit providers from even sending a bill at all for the in-network cost sharing until they've gotten word from the insurance company about what the correct amount is. Because there will still have to be some kind of billing, but we want it to be the correct amount. And third, base the default reimbursement or the presumptive reimbursement, as Professor Hall called it, to out-of-network providers on the average contracted rate or Medicare plus 1%. In California, we ended up with Medicare plus 125%, the greater of that or the average contracted rate, and create an independent dispute resolution process for providers and plans to allow for speedy, inexpensive resolution. And this is basically what the new California bill enacted this year does provide. As an adjunct issue, not a substitute, but an adjunct issue, I would say that correcting the provider directories is also essential. It's right that it won't take care of this surprise billing problem, but it may in some cases help people avoid going out of network. And it may also give regulators a cross-check mechanism about network adequacy, which is really hard to track. While the comprehensive solution is ideal, I totally agree with Professor Hall on that. We know that legislation is the art of the possible. And so in many states, they've started out with emergency room protection or HMO protection. And we take what we can get to some extent. We aim for the moon, but we'll accept something a little less if it takes away some of the pain that consumers are really experiencing. And of course, I've mentioned the states, but we would love a federal solution, a comprehensive federal solution that takes care of everything. All the self-insured folks as well as the commercial market would be terrific. So Congress does need to act, I agree. A leader in this has been Congressman Lloyd Doggett, who has a bill he's introduced that would take care of the balance billing in emergency situations, but certainly more is needed. The paper notes that Congress could simply give states the authority to fix the ERISA plans in their state, and that's an interesting alternative that seems like something simple that Congress could do that would at least empower the states to move. As to bad policy ideas, there are a lot of them. Professor Hall listed a number of them, and I'll just tick off a few things. Requiring consumers to go to mediation regarding their bills is a bad idea. Our survey last year found that people just don't complain. 90% of people in our nationally representative survey didn't even know what state agency was charged with handling insurance complaints. So when consumers have to initiate the process, it's not a good idea. Instead, the law explicitly needs to set the amount as the in-network cost in these defined circumstances. and have that kind of clarity and then prohibit balance billing. In Texas, they've tried this. They do have a statute that requires consumer mediation and even sets dollar thresholds, and there are problems with it. So consumer advocates there are trying to work that out and amend that. Another inadequate solution is the notice point that Professor Hall mentioned, assuming that notice alone is enough. People just don't have the opportunity in many of these situations to shop around, and that's certainly not going to be sufficient. And in a foundational sense, I'd say that basing out-of-network provider reimbursement on billed charges may simply perpetuate inflated costs and unreasonable system costs, which in the end drives up premiums for all consumers. There's just really no basis for believing that all those billed charges are reasonable charges. In fact, studies have shown, as you all know, I'm sure, that billed charges are many times the Medicare rate. And I would just add that there's a lot of griping about the Medicare rate, but Medicare rates are set by a committee, the RUC committee, and don't ask me what the acronym is, I always forget. But it's a group of doctors and dominated by specialists, which examines what the appropriate intensity of the service is and what the appropriate rate is. And there's been complaints about that being dominated by specialists, the very specialists who are now saying the Medicare rate is too inadequate. So anyway, in conclusion, I would say that it is not a red or blue issue. Every legislator on the state and federal level and every staffer we've talked with knows someone who's had this problem of the surprise out-of-network bill. So the issue really has traction. And in 2016, nearly 24 states took a step of some kind to try to address the issue and protect consumers. Not all succeeded, but many were bipartisan, and we're hoping that in 2017, the states and Congress will come back and really try to tackle the issue because it's a major pain point for consumers.
Thank you very much. Tom?
Great, thanks. Good morning, everyone. Before I begin my remark, a quick disclaimer. My comments from the provider perspective hopefully represent many and maybe even most provider perspective, but I want to be clear that it doesn't represent all provider perspectives, so offer that in the beginning. Second, quickly, the context in terms of where I'm coming from at Cedars-Sinai, and that is that we have about 2,000 physicians who are associated with Cedars-Sinai. About 2/3 of them are in some sort of aligned economic relationship with the institution, but 1/3 of them are also private practitioners. I bring this up because as an organization, and this is not uncommon in other organizations, this is an issue that we deal with both as a provider of physician services, but also as a hospital in which private practice physicians are coming to treat their patients every day. In terms of the issue, I think the root of the issue really is the tension that we continue to struggle with in healthcare. It's not unique to the question of out-of-network coverage between market forces, and on the one hand, and also having a regulatory framework that is adequate to address both broad public interest issues as well as individual patient issues. And in that regard, again, this is not a kind of a unique item. We really don't have we don't have any sort of overarching mechanism, either at the state or federal level, to deal with these kind of issues holistically. And so, once again, on this issue, we find ourselves in a situation where there's enough social interest in a matter of sufficient economic consequence for people that you get political action, in this case, on a specific item. The rest of my comments will be oriented towards AB 72, both because I think they do represent some of the principles that were covered in the article and the prior speaker, but also because that's my own reality and our reality in California. It's one I can speak to the best. First, I want to start by saying, I believe, and I think many providers believe, that we're very glad that the patient is being taken out of the middle of this. I think, unfortunately, as we struggle in the American healthcare system around some of the issues I described earlier, we oftentimes fail to think about how do we keep the patient out of the middle of this, and I think the fact that's occurred is a good thing. In California, it comes on the heels of prior actions. This matter has been dealt with as it relates to hospital services out of network and emergency department services out of network, with prior legislation in California on both of those. The law starts on July of next year, and as plans are issued, amended, or created, and which is important language I'll come back to in a moment with regard to the implications. As the plans are issued or amended, there is a provision that essentially prevents patients from having an out-of-pocket cost for out-of-network services any more than they would have had as in-network. So that's the definitive solution in terms of the individual patient's out-of-pocket. There is a mechanism for at least 24-hour consent by the patient if they are to have an out-of-pocket payment more than that. So it does provide for that mechanism that was mentioned. In terms of the payment rates will be determined by the average in a particular region. The region, it's how the region is going to be defined is yet to be, as with many of the regulations, is yet to be answered, or 125% of Medicare, whichever is greater. There is a provision for an annual increase according to medical CPI, and there is a provision for independent dispute resolution if there is an issue with regard to the rates. There's a network adequacy requirement, so the issue of providing an incentive for the health plans to have an adequate in-network network in the area is an issue that the law addresses. It uses a 15-mile or 30-minute rule to determine network adequacy, which is probably okay in some parts of California, but in Los Angeles, where it can take an hour to go 4 miles, I'm not sure exactly how that definition works. The law does not apply to emergency circumstances. As I said earlier, that's been covered by prior legislation and has been observed by the prior speaker. It doesn't apply to ERISA. So, from my perspective, I've been in California for 38 years. I would just observe that I think the root cause of this has been a 30-year tug of war that has existed between physicians and health plans over what is fair and reasonable compensation. That's not a critical statement. That's the reality of how markets work, but it is, I think, what has led to this. And we have a solution now. We have a political solution that has pros and cons associated with it, like all political solutions do. And as I said earlier, the most important thing is the patient's out of the middle. Whether the balance between the market power balance between health plans and physicians has been reached as a result of the legislation, I think it's too early to tell by definition. A couple of things about the law that I would just mention as possible concerns and to keep an eye on going forward. First, by definition, the law does create, in essence, a rate cap, and there are issues. All of the issues associated with rate caps are potentially at risk. Given the way that the rate system is set up, there is an incentive for health plans to lower the payment rates to the higher paid physicians or physician groups, whether those are deserved or not. But there is that incentive, because by lowering the higher limit, you will lower the average payment rate, which is what would be used. I think for many community hospitals, they will find themselves being approached again by various specialists who will be looking to the hospital to provide some payment to them in order for them to be available for services that patients in those hospitals may need. As physicians seek what they think is an adequate income level, they will seek that income from whatever sources might be available. There is increased administrative complexity associated with this. Again, not a reason not to do this, but I also think we should be honest with ourselves and acknowledge that, because that does come with a cost. In California, the complexity is maybe more complex because we have two regulators. We don't just have one regulator for health insurance, we have two. There are conflicting rules of how an emergency case is defined between those two regulators as of right now. I mentioned earlier the rolling implementation. So this will take effect as plans are issued, as new plans are issued. And so for those people administering physician billing, over some period of time, they will be dealing with, is this an AB 72 patient or not? Many of the implementing regs have not yet been written, including exactly how the independent dispute resolution process will work. The law calls for a certain way for the rates to be determined between now and 2019, and then in 2019 there's going to be an Uber solution to this, and so that is unknown exactly how it's going to play out. And then the ERISA issue. So I think that there are legitimate issues to keep our eye on in order to make this successful going forward. My last comment is, I do think that that this is an example where the issue of creating healthcare services organizations, more economically aligned, integrated organizations that are inclusive of hospitals, physicians, and perhaps others, is a good thing. I'm sure there's probably a meeting here tomorrow about why that's not a good thing. But I personally believe it's a good thing for other reasons. But on this matter, it is a good thing, because it does allow institutions, in the course of their relationship with physicians and that organization, to be able to put in place the kind of mechanisms which we've done at Cedars-Sinai, which is physicians who are aligned with us in that way either agree to accept out of in-network payments, or some mechanism is established where this issue is taken away from an individual patient situation. There are implementation issues associated with that, and we wrestle with that every day, but it does create an environment. People have raised the question, why can't, and the prior speaker mentioned, why can't this be done through the hospital-physician relationship, typical hospital relationship? And the reality is the nature of the hospital-medical staff relationship is just not designed, frankly, to deal with these kind of issues, and that's why it hasn't been dealt with until now. So.
Thank you. Great. Colin?
Well, good morning. I'm Colin Drostowski, and I'm pleased to be here today, so thank you for having me. I'm with Anthem Blue Cross and Blue Shield, and we'll bring to you the perspective from the payer's side. In my professional career for the last 25 years, in some way, shape, or form, my team and I have been provider-facing, so this problem is very real to us on a day-to-day basis, and I'll try to give you some practical observations that I hope will shape and inform our conversation. From the perspective of the health plan, I think it's safe to say that we can sort of generically and loosely classify physicians into two categories. Those who want to contract and work with payers, and frankly, those that do not. Those who want to contract and work with payers represent the overwhelming majority of physicians, and there is that healthy tug-of-war that Tom referenced, and that exists and has existed for decades. Mm-hmm. That I don't think is going to change. The much smaller category are those physicians who really are seeking to game the system in some way, shape, or form. And candidly, I think they're seeking to game the system at the expense of the patient, at the expense of the consumer, at the expense of the employer, at the expense of the healthcare system, and at the expense of the health plan. So that's sort of the category in many ways that I think we're talking about today, where you bring in this idea of the surprise bill or the balance bill. From the viewpoint or the perspective of the consumer or the patient, I would say that they also classify non-participating, non-contracted physicians into two categories. Those that are non-contracting, that they have the opportunity and the awareness of that they are non-contracting, and therefore in advance of care, they can make a reasonable decision, a reasonable determination of what is best for them. Do they want to continue to receive these services from a non-participating provider, or do they not? And then the other category, which again is what we're here to talk about today, those instances where they really don't have a choice in that physician, or the choice is made available to them so close to the event that it's not practical for them to sort of cause a pivot or a change in care. The problem of surprise bills or balance bills is not new. As I said, it's been ongoing for as long as I've been in this industry. What I would suggest is that there are two things that maybe are new or different. One is the degree of the balance bill. What we are experiencing at Anthem on behalf of our consumers is that the amount of bill, the amount that the consumer, the patient, is now being subjected to is growing and growing exponentially. It's not uncommon to see a bill for $100,000 on a service that at a contracted rate might be $5,000. And we have more egregious examples than that. And the other piece is the breadth. Historically, this problem generally has been constrained to or confined to what are known as hospital-based physicians. Think radiologists, anesthesiologists, pathologists, emergency room physicians, neonatologists. That's generally the cluster of physicians where this surprise bill existed. The breadth that I'm referencing is more in this creative solution that is really, really detrimental to the consumer. And the best example I can give you is a physician that's a surgeon will either employ or work with an assistant surgeon. And this is a designed scheme, if you will. That physician, the primary surgeon, will contract with the health plan or will contract with all health plans at their standard rates, but he or she will then bring in this non-participating assistant surgeon into the OR, and in some cases, or many cases, where that assistant surgeon isn't even needed, and then the patient finds out after the surgery, because they were frankly unconscious at the time, that an assistant surgeon was brought in, and now they find this bill for whatever the amount may be. That breadth is somewhat new to the equation. And I think it introduces a unique and distinct dynamic to this problem. I know that time is tight, so I'll abbreviate my comments. There are no simple solutions, right? You've heard that from every single presenter. It is a complex problem. I would agree with all of my predecessor presenters that there is a shared desire to address the problem. There is no one single solution that I think is most fitting. I agree that the professor has brought forth some very thoughtful solutions, but those in and among themselves are not easy. What I'm going to leave you with are just simply 5 observations that maybe will provoke some thought and discussion and questions as we move forward. But it's really to describe how we as constituents in this process either introduce intended or in some cases unintended consequences that are contributing to or exacerbating this problem of surprise bills. And so I'll start with the one that I began with. And these are, by the way, not in any particular order, so don't think that the first is most important. I think they're sort of all of equal concern. But the first here is physicians, right? I mentioned at the very beginning that there is a subset of providers that are really seeking to exploit the system. And there are multiple ways that they might do that. They might do that through federal EMTALA laws or emergency laws. They might do that through local or state laws that require certain payments for non-participating providers. They might do that through health plan policies around how they do or do not pay for non-participating services. So that's option 1, or observation 1. Observation 2, regulators. And I want to be clear, I believe that a regulatory solution is an important part of this problem. But with the best of intentions, some of our existing regulatory solutions could actually serve as contributors or exacerbators to this problem. And that is if they require payment of billed charges in all circumstances, or even in emergency circumstances, without a reasonable cap or a reasonable way to set what those rates should be. The one that I don't think has really been addressed in this room, and it's not one that's immediately self-evident, although I think the professor addressed this idea of self-funded employers. And if you're not familiar with that term, that means that about 50% or more of the healthcare insurance that exists today are rendered by employers who are responsible for that payment, not health plans. The risk of the medical expense resides with those employers. And because those employers, particularly the large jumbo accounts or the national accounts, in some cases have the best interest of their employees, the best interest of their dependents at heart, they're saying we need to pull them out of the equation. And that's a good thing. Let me be very clear, that's a good thing. But in doing so, what they're saying to the health plans is we want you to pay billed charges. And so what does that do? It creates this unintended incentive for those providers who are non-participating to say, wow, if 1 out of every 5 or 1 out of every 10 times I see somebody, I get paid billed charges. They may not know exactly why they're getting paid those billed charges, but it's like winning the lottery. And not only is it like winning the lottery, they get to set the amount they win. And if they don't like the amount they're winning or the frequency by which they're winning, they simply increase their charges. So there are unintended consequences there. Health plans, right? Certainly, I think you have to look at the health plan and say, in our efforts to make healthcare affordable, in our efforts to narrow networks and to optimize care, one could say, have we gone too far? Are we setting rates that are not sustainable, that are too aggressive? It's the tug of war that was described. And lastly, the hospital component to this. It is clearly prudent for hospitals to issue contracts for certain hospital-based services, right? It's efficient to do so, and they typically will bid those in some process and typically award a single contract to an anesthesia group. So that group will supply all anesthesia services at a hospital, or that group might supply all ER services or all radiology services. And it makes good sense to do so. But in doing that, you then create sort of a monopoly provider who can say, well, I'm the only access point you have for anesthesia at this hospital, or I'm the only access point you have for pathology. And that problem is not new, but what is also occurring, and one of the speakers alluded to this, is that the hospital-based groups are also coming together. So even if you were made aware that at Hospital A, the emergency room group was non-contracted, you think, well, send me to Hospital B. It's now possible that Hospital B is also staffed by that same emergency room group or that same pathology group. And so the consumer finds themselves stuck in the middle in terms of you have statewide or regional monopolies of hospital-based providers that are complicating that problem. So I will stop there because I know our time is tight, so thank you.
Well, we'd love to hear from the provider after. So, Jeff?
Thank you. So I'm the physician on the panel and the provider. This is going to be interesting. I'm heartened to see that we do agree on several things, but the provider's viewpoint is what has been missing from a lot of dialogues in this regard. And even in the creation of the white paper, I don't think I saw a provider as part of the team. So we're going to shed a slightly different light on it, and we look forward to the questions and answers afterwards. So I am the incoming president of the American Society of Anesthesiologists. We're about a 52,000-member healthcare association, and for those of you not familiar with physician anesthesiologists, we're the highly trained medical experts who evaluate, monitor, and deliver vital care to patients before, during, and after surgery. So as a physician, my training is in medicine, not medical insurance. Unfortunately, in this new era of increasingly confusing insurance products, we're caught in the middle with our patients who are forced to purchase complex insurance policies. Regardless, these are our patients, and helping them in any way that we can is part of our DNA. So this is a multifactorial, multifaceted problem that really is not understood by many at all. Proposed solutions just addressing symptoms instead of the root cause are flawed approaches similar to just treating symptoms of disease instead of focusing on patient wellness and prevention of disease. We believe balanced bills are symptoms of the issue. The cause is gaps in insurance coverage. We appreciate that the media has brought this issue to the public's attention, and we look forward to working with other stakeholders here and believe that the most successful solutions can only be formulated by working all together as a team. Our primary goal is ensuring access for patients to care inclusive of all services that they or their family may need. This is not the situation for many unsuspecting patients right now. What we have learned is that the problem is not really the surprise bills as much as the problem is surprises in what insurance covers and doesn't cover. Specifically, insurance companies are failing to create adequate and readily accessible networks. There are multitudes of reports of insurance companies narrowing networks as a strategy to limit their cost and to shift those costs to patients and other stakeholders. By tiering and progressively narrowing the networks that they create, insurance companies are only exacerbating the problem that originated from changes in health insurance that were introduced by them in the first place. Unfortunately, patients learn the hard way about gaps in insurance coverage, not when they purchase their insurance, but when they hope to be covered by it. All is good when patients are healthy and not needing reliable insurance coverage. Monthly premiums are affordable and network adequacy isn't even on their radar. But then a need arises for healthcare services, possibly in an urgent or emergent scenario. Then the surprises pop up. Unaffordable copays, high deductibles, and payment denials front-loaded in amounts that can be devastating. All as a result of the deliberate cost shifting. As if narrow networks were not complicated enough, tiering makes it even worse. Providers can be in-network with a carrier in one tier, say for example the gold tier, and out-of-network with the same carrier in another tier, for instance the bronze tier. So when transparency about insurance coverage is proposed as a solution, it's incredibly important to understand that only the insurance companies know day-to-day who is in and who is out of networks that they construct. We don't even know at times. Maintaining accessible networks with adequate numbers of all providers and all services, as well as a mechanism for fair out-of-network payment, are the keys to solving the problem. Patients work hard for their insurance policies. With the complex design of all these products, it's incredibly difficult to discern what policies truly provide consumers. Physician organizations across the country are now working together to promote the rights of patients to have well-defined, effectively communicated, easily understood, and fair minimum standard benefits. And again, legislation that would solve these issues must include preventative strategies attacking the cause of the problem and not just the symptoms. My family fell victim to this problem too. Now listen carefully, because our story epitomizes what has happened to insurance coverage in this country. Not only am I deeply involved in insurance coverage in this country, but my wife, current president of the Texas Society of Anesthesiologists, has been working for over a decade advocating for patients struggling with insurance that fails them in times of need. We learned firsthand of the gaps, complexities, surprises, and frustrations with our family's insurance with her mammogram. She needed a biopsy. After communicating with her hospital and our health insurance representatives, we were very disappointed to learn the procedure had to be performed at a competing hospital, the only one in network, if we wanted to avoid thousands of dollars of cost to our family. We spent considerable time and effort, and I mean considerable, asking detailed questions on both the payer and the provider side of this equation. We did our homework. We were assured that this was a woman's preventative health service, which therefore was said to be well covered, and we were really excited when both sides said all we would have to pay is $150. Thought, great. After her procedure, we received both good and bad news. Benign, thank God. But bad news followed 6 months later when we received a bill for $1,800. In spite of arguably being the experts on this subject and doing all of our homework, we still received an unexpected big bill. After all of our work to be aware, responsible, and informed patients to safeguard against some surprise, we learned firsthand of the gaps in our coverage. Once again, we got a bill 12 times what we were told to expect. Regarding the white paper, I applaud the professor and his team. There are a number of components and recommendations that we agree with. I'd like to note, however, the white paper is based on the assumption that patients are billed by out-of-network providers, even though the patients did all they could to remain in network. With my personal experience I just shared, I'm quite sympathetic to that scenario. However, it should be strongly understood that the vast majority of physicians want to be in network, as my friend said. With networks narrowing and tiering, the frequency of surprise bills is increasing. The truth is that there are very few physician outliers sending exorbitant bills. That has been shown. But the insurance lobby is claiming to the contrary and inaccurately yet persuasively portraying few examples out there as the rule rather than the exception. In a free market capitalistic economy, there will always be a few charging higher rates for whatever they sell, and in medicine the emphasis should be on a few. A small minority of physicians send these huge bills. The vast majority of physicians report they want to be and try to be in network and are met with, we don't need any more physicians, we're full. We want the patient volume that comes with being in network. We want the stability that comes from being in network. Our practice administrators really want us to be in network so they know what to bill and what they can expect that we will be paid. So their narrative is not true. It's not that we won't come to the table to negotiate, which I've seen printed in the press in multiple places. We aren't being allowed at the insurance company-controlled tables in many instances. To summarize, physicians want patients to have ready access to physician networks capable of providing the care and services that they need. The best solutions will maintain incentives for insurance companies to appropriately negotiate in good faith with physicians for adequate, complete, and comprehensive networks. We worked on solutions to this, and we propose a big solution where BIG, an acronym, stands for Ban Big Insurance Gaps, because they are the cause of balanced billing and the surprises that come with them. We've also learned through our studies that patients want and expect physicians to help them with this, and we see that physician perspectives are missed by many, including many proposing solutions. So we are too looking for just the right porridge. Thank you.
Thank you. I'd like to ask all of you a few questions, but Colin, you spoke about providers trying to exploit the system. Jeff has set up an alternative view here, which is, and we saw some data from Mark suggesting that the networks in Texas are inadequate. And so the result of this is that people don't have access to some providers that they obviously need. How do you respond to that?
I would first respond by saying I think that's a situational issue, but in general, if you look at what provider types, what specialties tend to be at the core of these surprise bills, I would dare say that certainly Anthem and most insurance companies do all that they can to have them in all of their networks. I agree that narrowing, I think you made reference to it, is certainly part of what we're looking to do. But when we as health plans think of narrowing networks, it does not immediately mean, boy, we want to narrow radiology, we want to narrow emergency room, we want to narrow pathology. That is not where we're going. It's in the broader areas where we see greater variation in care, we see greater variation in cost, where there's increased competition among those particular specialties. But while I appreciate his comments, the data would say that where the balance bills are coming from are in those specialties that we're certainly not looking to narrow.
And Tom, you've set this up in a way that the hospital is a neutral party watching, in some sense, the insurance companies duke it out with the professionals. But it really, in some sense, it's not that case, or maybe I've misinterpreted your position.
Right.
What role does the hospital play here, and how can they solve this?
Yeah, if I gave anyone the impression that hospitals are neutral parties in this, I want to correct that impression completely, because that's not what I was trying to say at all. What I was trying to say in part is that, first, at a minimum, there are what I'll call the typical community hospital, which, among other things, has the hospital-based specialists of anesthesia, pathology, imaging, emergency services. And for those hospitals, they may not be they're not responsible for the professional services, but they experience the consequences of how this matter plays out with their patients. And so those hospitals are very much in the middle of it. And I think those hospitals are trying to do what they can, given the nature of the relationship that exists between what I'll call the typical community hospital and their medical staff, which is largely, frankly, a matter of trying to influence and convince people to willingly go along with a particular outcome. And you get the variation that this conversation is based on. There are other organizations, and my own and others, where we do have the kind of relationship with physicians, because we're healthcare services organizations providing hospital and physician services, where in the course of establishing those relationships, as was mentioned by our first speaker, that there is the opportunity in that context to have the conversation to make it a matter of contractual relationship or other vehicles that can be used, so that, because you have aligned economic incentives, those aligned economic incentives in today's world are very much oriented towards meeting consumer needs. And
So-
that's the difference.
I see, but so if I could, let me come back to the specific thing, because we've heard, suppose there's an anesthesiology group out there, to take one example, and they're really dedicated to patient service, and they're a little frustrated with the dealings with the plans that are predominant in the market, and so they're not contracting with the two plans for which those are most of your patients.
Right.
What is the response of the hospital in that case? I mean, you could go, and Jeff, I'll give you a chance as well. Right. You could kick them out of your hospital, or you could go to the plan and say you need to have these people in. How does that get?
I won't go into all the details, but I think people generally can appreciate the benefit that can accrue to the patient in terms of both quality and efficiency of operation when there is a contract with a single anesthesia group to provide those services, as opposed to, frankly, I've been in the business almost 40 years. I've seen hospitals where it's individual, and it's chaos, frankly. It's chaos. So I think there's a very good patient interest question for why having a contract with the group. Once that's in place, I do think the hospital, either through its contracting, has a responsibility to try to secure either agreement from the anesthesiologist that they either participate in the plans that the hospital's a part of, or if they're not, because there can be reasonable disagreements that exist, effectively the anesthesia group would agree to a mechanism whereby patients who are treated under those plans aren't going to experience this surprise bill phenomena. So there are ways to deal with it.
Okay, I'm going to give Jeff a chance to respond, and then I want to bring it back to Betsy.
So I'll give you some real experience that relates to this, so you can get the picture, because again, the clinician or physician side of this is often missed. For background, I was the president of my group. I had all the interaction with the administrators, but more importantly, I was the payer liaison for all 400 plus anesthesiologists in the state of Alabama for about 12 or 13 years. And I dealt with the largest insurer in Alabama, most of you probably know who that is, on a very regular basis, as well as the Medicaid agency. Very sensitive to the issues of the payers, and we were actually told that we had the most constructive relationship with the largest payer of any specialty that they had ever dealt with. So that's kind of the background. We were not in network with all big payers. Why? We were with the largest. Why? Well, we were a group that was rock solid top to bottom, very good, professional citizens involved at all levels, doing good work, having good outcomes, et cetera. And the one particular large payer that we would never contract with only brought to the table offers that only somebody desperately in need of business would take. So if you look at data at our institution, it might draw some conclusions about the anesthesiologist not being willing to sit down at the table and negotiate, when in fact the opposite was true. I sat down and talked with them about it all the time. Before I left and moved to Texas, I was real close to having something cinched, but that was after working for a decade. And I can share stories of my colleagues in Texas that tell me the same. They're trying, but when competitive pricing isn't offered, you have to remember all physicians are private businesses as well, and in our specialty it's crucial that we negotiate those commercial contracts well because of how poorly the government pays anesthesiologists. Facts show, the government accounting office shows, affirmed that anesthesiologists are paid lower than any specialist by Medicare, 30 cents on the dollar. Medicaid in Alabama, to use that as the example, we were the 5th lowest. We were paid, I think, $10.72 for every 15-minute unit, $10.72. So if your government-funded patient population is in the 45% range, and then you accept commercial contracts that are well below average market prices, you'll be out of business. You won't be able to recruit and retain. So if the prices that we're paid for our services are not directly related to real market value rather than artificially created values by Medicare and Medicaid, and we can get into that. The RUC does work, but they start with a budget. The Medicare, Medicaid prices are budget-driven. They are not market-driven. So there's strong argument for not using them. But again, when we're paid that low, you have to negotiate right. Some people commonly say, we hear this from the insurance lobby, oh, they commonly bill 300% higher than they should. Well, that's because you'd have to increase Medicare rates 300% to come up to commercial rates, okay? And there's a reason why billed charges are oftentimes higher. It's because physicians throw a bill out there not having any idea sometimes what it's going to be cut to. We don't know. We can't predict what we're going to be paid. We can bill what we want to, and there doesn't seem to be a predictable, consistent amount that will get paid in return. There's a lot of confusion there, lots and lots of confusion, and that's what we would like changed. Things need to be simpler. I may be the dumbest anesthesiologist in the country, but I ought to be able to figure out my estimation of benefits document that I receive 6 months later. I oftentimes can't. It took me forever to try to figure out what insurance product to buy. I thought I bought the best one, but obviously I didn't. We still got surprises.
So Betsy, you've heard there are clearly market power issues here and policy. There's near virtual unanimity among everyone that the patient shouldn't be held responsible, which is, I think, good news for perspective. On the other hand, there are questions of the policy reforms might set up, for example, setting rates, as Jeff has argued, low rates could create problems of access. On the other hand, as Colin has pointed out, high rates could limit the ability of insurers to get discounts. Is Consumers Union, are you worried about access issues as a result of legislation, and how do you monitor those types of issues?
Yeah, we're not so worried about the access issues, although we'll, of course, be watching it, because back in California, as Tom referred to, in 2009, we resolved the emergency room issue, reimbursement issue, and didn't find that there was an access problem created. So we don't have a reason to really believe there's going to be access problems, but the marketplace is dynamic, so of course we'll be watching it closely.
I can tell everyone here that you can get an ambulance in Los Angeles, so I know that's not a worry. So
It is, but we didn't even talk about air ambulances, a whole other issue, which I know Blue Cross is looking at. People getting, again, these just whatever the market will bear prices, then they're not in network, and we're talking, $100,000. But if I may just comment on another thing that Jeff said, I mean, there are some points we agree on, which is about the complexity of the system for the doctors, for the patients. The tiering adds an extra layer of confusion. It's nearly impossible for anyone to figure out their insurance. That is true. The other point was that he said that there were just a few providers billing at these huge rates. Well, we're not just worried about the $30,000 example that I started off with. We're talking about $100, $500, $1,300 bills, and it's all relative what's a big bill. When you're scraping by trying to make the rent and put food on the table, $100 is a lot of money too. So as people are paying their premiums, which we all know are going up all the time, we want to make sure they're getting the value for their dollar, and even $100 more is not going to be easy for a lot of people.
Sure, I think that's right, but I think, as I noted at the introduction, and one question is, sometimes we want to use copays and deductibles, and there are places where they're appropriate. For example, we want to steer people to providers, I think, when they have a choice and when they can make an informed decision. I think the challenge here is what happens, obviously, when it's thrust upon them by the vagaries of healthcare.
That's the topic today, is when it's not their choice, when it's not an informed decision. Right.
We're going to open it up to the audience for questions. We have about 15 minutes. If you could state your affiliation and then ask it in the form of a question rather than a soliloquy, we would appreciate it. So why don't we start the woman back. We'll start from the back and work our way. The woman back there with her hand on the aisle.
Thank you, sir.
Oh, in blue.
Thank you so much.
Good morning.
I try.
Karen Feldman with the AFL-CIO. Our affiliates bargain health plans. Sometimes they jointly administer them with employers. So I was sort of confused about some of the descriptions about self-funded plans and allowing states to do regulation. Could somebody explain
Yeah, I think the
more about
confusion
that?
is over ERISA and who is subject to state regulation. I don't know if Colin or Betsy wants to talk. Well, Betsy seems.
Yeah, the Department of Labor is, charged with, as I'm sure you know. You're an expert, I know. Well, I think what the professor was,
That's not actually a question.
do you want to address it? Because it's your suggestion. Yeah.
Mark, why don't you come up? I'm going to invite Mark up we're going to make it a question. Now you put why on it.
And I think we need to think more about what solutions could work legally. So one is just to have new federal legislation that takes over the whole field, but we don't see that very often, and we've seen it with respect to mental health parity and with respect to coverage of first dollar coverage of preventive care, so it's not impossible, but short of that, what could be done? Well, one thing that ERISA does allow is for states to regulate provider rates, and so if they're not regulating plan payments, but provider rates, there might be some sort of regulatory vein that could be pursued. And so New York has a process where for uninsured and for those in self-funded plans, they usually we keep the patient out of it, but with respect to self-funded plans or uninsured patients, you can't. So they allow a process where the patient assigns their claim to somebody who, resolves it with the provider, and that apparently could be done under ERISA.
Thank you. I think we want to take some more questions. So the woman with her hand up in the middle of the... Your left. Right in front of you.
Right?
I give up.
There we go.
Thanks. Alwyn Castle with Policy Translation. And I have a question, but I have a clarification that I'd like to make first. You guys, I know we're talking about surprise medical bills, the anesthesiologist, the pathologist bill that I have no idea that I'm going to go out of network on. But I think there's an upstream problem that you're not talking about that is related, and that is you're assuming that me as a consumer, I as a consumer, in a PPO can make an informed choice to go out of network, and I would say, no, I can't, because I can't get Mr. Drozdowski to tell me what his out-of-network payment rates are based on. So I can't make an informed choice. I'm covered by Anthem through a Fortune 50 employer and have had the experience of going out of network knowingly to find that when I get the bill for that service, the out-of-network allowed amount is less than Medicare, less than what Fair Health allows, and then when I try to get a question from Anthem or get an answer from Anthem about how do you base your out-of-network payments, they say, oh, well, you'll have to call.
Okay. The question is clear. Colin, I think, do you want me to summarize, and I'll go with Jim?
Yeah, if you want to, I'm happy to.
She wants to know how much you pay for pathology.
I like your question better, but that was not what I heard. First of all, let me acknowledge that all health plans need to do a better job at informing consumers. I'm not going to shy away from that point, ma'am. It's a valid point. There are complexities that make it nearly impossible. We can tell what we will allow in a non-emergency out-of-network situation. What we cannot tell you is what will you then be balance billed on top of that. That becomes an issue between you and the rendering provider, because by definition, they're not in network. They can say, well, I need X amount of money for this, and Anthem will say, we will allow Y, and you can have that negotiation. Depending on the service, we have that ability today, but we also don't know in advance exactly what it is the provider will be billing. And so when they have the specifics of the bill, it's then easier to say, this is how much we're going to allow. But it's not as easy as saying, well, you're going to have your knee replaced. Well, what exactly is going to occur in that episode is a challenge. I'm not defending the fact that we need to provide more information, because we do. We need to have better tools as an industry, we do. But it also is dependent on knowing exactly what it is you're going to have and what that provider will bill.
Can I just follow up?
No, I'm actually going to let Jeff follow up, and then I'm sorry.
I might actually help you. I love your question because I've been in that position. And I'll defend the insurance companies a little bit, because one of the problems is just human factor science. A lot of people, even if the information was there, don't dig for it, don't look for it. It's only, they back shelf it, they don't need it, life's busy, everything's going on fast. Then all of a sudden they need it, they're calling in an urgent situation, they can't get the information for one reason or another, or there's not time to. So that's one thing. I get that. It is really, really hard, and I think it's really impractical to think that the average person, again, my wife and I we're pretty savvy consumers, especially as it relates to this. We couldn't get the information we wanted. The information we got was grossly inadequate. So everybody put that away. I have a hard time finding out what the allowable is. So if you look at the right-hand corner of the graph in the white paper, bottom right-hand corner, or really the right-hand margin, you think about a PPO where patients are agreeing to pay more money to have more flexibility to go out of network, to choose their institution and their providers, and then look at the numbers. Right off the bat, the $10,000 is discounted 60% to $4,000. I don't know how that happens, why it happens, who decides. I think it's random. Not random, but it's unilaterally decided by the insurance company, but I don't have say-so. The patient doesn't have say-so. And then if you look at the worst-case scenario, the amount of money that patient knowingly paid more insurance for is really, in the end, costing them an exorbitant amount of money. The complexity is at the root of the problem. Surprise bills are coming because the products are so complex and confusing, the average person can't figure it out. And if you look at in California, yes, there was a huge complaint brought by the payers and the consumer advocates that 30% of people were getting surprise bills. It's super important to analyze what surprise means. So the the California legislature sought a solution, and they commissioned their own study. And of all those cases they looked at, the 30%, guess how many were truly caused by being out of network by the providers? 0.2 to 0.3%. All the rest of them were surprises because of the big deductibles, co-pays, allowables, denied care, etc. They got a huge bill. They're paying insurance, but geez, I just got care, and I've got a bill that I got to pay that's thousands of dollars. That's the problem.
I think, there's a broader question of price transparency that we could debate. I think what we've seen from Neeraj Sood's work on this topic is that some consumers are able to do this type of price shopping and would like access, but for most consumers who are sick and getting care for the first time, it's hard to do that type of shopping. We're going to go with Norm Payson here in the front, and then we'll come over here.
I'm Norm Payson. I have multiple categories as a person. I'm a past practicing doc and was in the health plan industry, et cetera. Dana, this may be a question for you. Because I know you're so good on the analytical aspect, and there's also perhaps for Professor Hall. Has there been any scoring as a percentage of premium in these different subcategories, whether it's surprise bill, non-par, delta between par and non-par, delta between allowable, et cetera, or if AB 72 comes into California, what will be the scoring that Anthem and other insurers would have, and then also the scoring of how that's going to affect the tilt between ERISA and non-ERISA. Will this encourage more ERISA plans to go fully insured because they're going to tilt in where they have a ceiling on non-par? So just wing out some economic questions.
So the physician is asking about the analytics, and the answer is none of us thought to do it until just now. But it's a very good question. There's a question over here, please. Thank you.
Sharif Zafran, I'm a physician from Texas. I'm actually an anesthesiologist. Dr. Plagenhoff, you talked a little bit about solving the problem through network adequacy and increased transparency and through fair payment. Can you describe a little bit exactly who and how would figure what exactly a fair payment is?
Sure, that's a great question. I think the New York legislation gives you an example of how you can have fair payment determined. So you got to understand or think about the history of what happened in New York. There was a big lawsuit, the Ingenix lawsuit, and a large, well-known payer was found to be doing their calculation of UCR internally, non-transparently, and they were found to be manipulating the data for their own financial benefit. So the result of that lawsuit was they had to pay $95 million to create an unbiased, market-related database of billed charges, real data, what people are billing. It's called Fair Health. And so the way that we could comprehensively fix this, whether it's at the state level or the federal level, is to agree to pay out-of-network providers a percentile of fair health. One of the other speakers said, actually the professor I think said 75%, 85%. Some people are advocating for 80% of fair health. Now, payers say, oh, those are not related to meaningful data, and that will just drive up costs. So in California, they looked at that, and they studied that, and they found that the 80th percentile of billed charges actually correlated with somewhere between 5 to 10% higher than in-network rates. So ask yourself, what would prevent insurance companies and physicians from being in this scenario? Well, if insurance companies had to pay slightly more for people to be out of network, they wouldn't want people to be out of network, because the more that are in network, the more money they'd save. The beauty of using the 80th percentile of fair health, or an agreed upon percentile, would be that not only is there a guarantee that physicians will be paid for their services in a meaningful, fair market value supported way that won't negatively impact access, but the beauty is when you're talking about the outliers, if the payment for the out-of-network physician who might have billed exorbitantly is based on 80th percentile of billed charges in a particular geozone of where people provide the same care, then that would be a way of nipping that in the bud as well. So it would play well on both ends.
I would like to make just a couple of quick comments about that. We are very supportive of working with regulators, working with providers for a solution, but to index it in any manner purely to charges is not logical. And with all due respect, a few minutes earlier, you sat here and said, I don't know what I charge, I just sort of put it out there. And so...
No, I know what I charge.
But that was what you did say. You said, I throw it out there.
I said
charges are not reflective of costs. And as the professor noted, it is very common for providers to bill 3, 4, 5 times what they regularly accept as payment in full, and what is exponentially more than what they accept from Medicare. And so I would respectfully submit that if you're advocating for something that is a function of a charge structure that is not well understood and that can be increased simply by every year increasing your charges, if you hold at 80%, a provider increases charges by 10% per year, 80% goes up by 10%, and there's nothing that can be done about it.
Betsy?
Yeah, this is a point on which we agree with the plans completely. And I would say that California did study it, and it's a sticking point, and not just in California, but in every state, about what is the fair and reasonable reimbursement going to be for out-of-network providers. But after studying it and looking at fair health, California landed in a different place, which is the greater of the average contracted rate, or Medicare plus 125% of Medicare. And we do want to get that Goldilocks point at which we're encouraging providers to contract, and it's a balancing act. Not every state lands in the same place, but we did study it and looked at fair health and decided not to go that way.
We have a question, Mark.
Can I just comment on that really quick? Yeah, 2 points I forgot to make about this very debate. One is that we might conceivably, and due to the complexity, unfortunately, adding more complexity, arrive at different balancing points in different areas. And so the extent of the relationship between charges and contracted rates in Medicare might reflect a certain average in one geography, but that average might vary widely from one specialty to another or among geographies. which makes it that much trickier and scares off regulators, but it's the reality. The other point is whatever you start with, we very much believe that it needs to continue to monitor, and we have a couple of good examples in Maryland and Colorado where they started with something, but they said, we don't know if it's going to be too hot or too cold or just right. So every 2 years we go back in and look, what's the effect on network composition? What are we hearing about the provider negotiations? What's the impact on access and what have you? So absolutely whatever we do needs sort of continuing sort of evaluation and fine tuning.
Sure. Yeah, we can't get it right out of the gate. This is going to be our last question in the back here, Mike Ryan.
Mike Ryan, BMS. First of all, I'd compliment Brookings and the Schaeffer Center for taking this subject matter on. It really is important for the nation. I would say the following. My question is the following. It's really, Dana, for you and for Professor Hall, which is what we hear when we survey patients and talk to patients is more and more what we're seeing is patients who are deciding to delay procedures, to not undergo required services and other things because they are frightened of their insurance. They don't, the high deductibles, they don't understand the tiering, they don't understand this issue of out of network as well. And so they're tending to use their insurance more and more as catastrophic insurance. And I guess my question is, from an academic perspective, has anyone bothered to really study what the healthcare burden of that is over time of people electing not to get the care that they need?
I'll start just by pointing out that I really want to thank the audience for pointing out things we don't answer rather than things we answer. It's much appreciated. Betsy, why don't you start?
But there is some work on this. Rand years ago studied high deductible plans just a couple of years ago and did find, that, as you're saying, people are delaying care. They're not getting the preventive care. I'm not sure that actually went as far as getting to the health impact. But
Yeah,
it's
and
a
actually it
concern.
does. So a good example, and Neeraj Sood is here, and he'll comment in a minute, but when you look at high deductible plans, when we studied them, a lot of them have carve-outs for preventive services, but what you find is people don't use those services even though they're free, and so the point is they don't really understand the plans. Neeraj, do you have a different view since you've written on high deductible plans? Why don't you come up as well? And then I'll invite all the audience to come up afterwards. Actually, at that point, we're going to stop.
Then we can go sit out there.
Everyone gets the mic here at Brookings. That's always been the theme.
So yeah, we've analyzed data from, for 40 or 50 large employers to look at the effects of high deductible plans. And what we find is that over a 3-year period, they do save costs, but people save costs primarily by just cutting down on use of both needed and unneeded care. So we see declines in use of medications for chronic illness. So rather than say, go towards a generic, they just stop taking their meds. We see people getting mammograms in December when they know they're going to be in a high deductible plan in January. Even though in January the mammogram is going to be free for them, they don't realize that. So you see the spike up in preventive care prior to joining. So in some sense, consumers are smart, but in some sense, health insurance is just too complicated for them. So they're trying to make smart decisions, but it's difficult for them to make smart decisions.
Okay, thank you, Neeraj. And I want to give each of you a minute to make a last concluding remark on this topic. So Betsy, we'll start with you.
Yeah, well, this has been a lively discussion. I really appreciate it. You, I think, have gotten a flavor of the complexity of all this. As I say, we need policy solutions in this area, and legislation is the art of the possible. So we're going to aim high, but we may have to take this step by step, and hope we will in the coming year.
Thank you. Tom?
Yeah, well, the die is cast to a certain degree in California with AB 72. So I think that, but like someone just made, I think, the comment, people tend to think that once legislation is done, the process ends. It just begins. Look at the Affordable Care Act as maybe the poster child for that. So I think everybody needs to keep their eye on what the implications of this are, study it, understand it, and be open to making the adjustments that otherwise ultimately look to be indicated. That may be the biggest challenge.
Colin?
I would simply say that forums like this and open and honest communications are necessary. I think if you've heard and learned nothing from this, this is complicated. And clearly, the best solution will come from collaborative dialogue with the parties, the providers, the members, the consumers, the employers. we're committed to that, and I think it's essential to get to a sustainable solution to this issue.
Jeff?
Thanks. We physicians are committed to being at the table, and we admit that we actually haven't been there well organized, but that is changing right now this year. We are coming together to stand up and fight for solutions that make sense. You can't base what was done in some states on necessarily the argument that it was the best thing. What we have seen in the states, and everybody in DC certainly knows how lobbying impacts what gets done and unions and things. In California, for instance, a lot of influence was weighed in the end by the labor unions, had a lot of influence on what got done, excuse me. So heretofore, a lot of money's been spent in the state houses deciding what to do. Physicians haven't showed up in big numbers. There are states where one doctor shows up to give the other side. Hearing from everybody is important. We want to be at the table. We are here to protect patients' rights. We want people to have good insurance, good health care, and we want it to make sense. We want it to be affordable. And I'm going to make one more plug for fair health. I think the numbers that were stated had more to do with Medicare than commercial insurance. Again, you should expect large multiples of billed charges as compared to Medicare, because Medicare and Medicaid are based on government budgets, not on market values. If you limit payment based on government budgets, you will negatively impact access to care. So realize that just because California didn't use fair health and they used a multiple of Medicare doesn't mean that it was smart or that fair health is bad. I will argue that there is a correlation. The facts show that in the analysis in California and in Texas, those numbers were meaningful. The insurance lobby continues to say that they're unmeaningful and 400, 500, 6% above what it should be. But that's compared to Medicare. So you got to be a savvy consumer, and we need everybody at the table aware of all of these details. Right now, there are examples of states where decisions have been made because of one-sided lobbying, quite frankly. So let's be smart about this for the American people.
Okay, great. Thank you very much.